That's okay. Good afternoon, everybody. Today is May 8th, and it is 1 o'clock. As a quorum of the committee is in attendance, I'd like to call to order the meeting of the Central Health Strategic Planning Committee. Our chair, Dr. Cynthia Brinson, is out today, so I'll be chairing for her. Let's see. I don't think we have any committee members participating by video conference today, right? Or do we? Ram's online. Okay. Just as a reminder, a committee member may also be participating by video conference, so the staff will be managing video and audio feeds of all participants closely to make sure we have a legally compliant meeting at all times. I don't see her. Can we see her? Hi, Maram. Can you hear us okay? Great.
Yes, thank you.
Okay, I don't see. Is he joined us yet? And there he is.
There's his ceiling.
Yeah, there's his ceiling. We like your ceiling, Amit. Ah, there we go. Okay. All right. Let's see. First item of business is public communication. I understand we do not have any public comments today. Is that correct? Okay. No public comments, right? Okay. All right. We'll now proceed to the committee agenda. The first item of business is to review and approve the minutes of the April 10th, 2024 Strategic Planning Committee meeting. I have a motion from Manager Valadez, a second from Manager Jones. All in favor?
Aye.
Okay. The motion passes. We'll move on to item number 2. Receive an update on the Central Health President and CEO's fiscal year 2023 annual report. I think Dr. Lee will be presenting.
All right.
I think you were just going to give us a high level.
Okay.
Perhaps you can point out to us what you might think is significant in the report in terms of the previous year's accomplishments.
Perfect. So thank you for the opportunity, Chair Kitchen and colleagues. Let me begin by thanking and acknowledging the team. JP Eichmiller and many members of our team worked long hours to pull this together, and I made a little bit of trouble and nudged a bit, and I'm really grateful for the team to have listened to my feedback and really produced what I am really delighted with. And so you see the annual report before you today. A couple of things that I'll highlight, and the managers know well, this year is different than any previous year in that we have begun to directly deliver care. The report closes out at the end of the last fiscal year, so just the very, very beginning of that. But this year, we are diving headlong into expanding access, sort of in a thin line across the areas of need. And by next year, you will see us begin to ramp up those services. So one thing I'll point you to is actually the back page, which is the looking ahead to FY24 section. This is a key addition that the team put in here, which I'm delighted to share. And you begin to see some of the key focus areas that I know we're all very interested in. So, and that page also shows you the build of the investments that we have made and are going to make with the strategic reserves that we have responsibly saved so that we could implement and build this whole new system over these next years out to FY30. So that's key. Kind of working backward, you'll see a new feature, which is our partner highlights. We wanted to make sure it was abundantly clear that there's a Central Health family that includes community care as the backbone of our system, providing the primary care strength upon which everything else is built, and Sendero, which is both providing care for thousands of artists and musicians in our community. On the one hand, they may be younger and relatively healthy by and large, and also providing the Platinum ACA insurance plan for our sickest patients, our most expensive sickest patients. So very interesting, innovative work at Sendero, and brings great strength to the system. Working backward from there, you'll begin to see just some sort of spotlights, images of our people and places, so you get a visual and not all text, And then in the middle, you see the highlights and milestones. You'll see a lot of specific areas here. This one does have a fair amount of text, so we've been doing a lot of good work. So if I highlight a few things here, during this past 2023 year, we really, we went live on Epic. That was a big deal. We launched the first service lines of podiatry, medical respite, skilled nursing, and GI care. These are, very targeted areas that are not always the first place that a health system launches, but they are some of the first places that our patients fall through the cracks, and they are tailored to meet some of the sharpest needs that our patients have. So I'm actually really delighted that the order of operations here is really informed by the knowledge of where our patients' needs are most acute. There's been a tremendous amount of engagement, if you look at that in communication engagement, so outreach activities, engagement events, increasing footprint in our digital channels. That's excellent. There is been ongoing work to make sure that we are providing accessible and inclusive care for LGBTQIA plus patients, gender affirming care, and at the risk of giving a little bit of foreshadowing, there is going to be a very exciting announcement around this, the result of years of hard and dedicated work, including last year. So I'll leave it at that, but more to come. We also began to ask, what did we learn from COVID? What do we need to do if there is a next pandemic? Let's not be caught flat-footed if we can help it. So that's very important. And then we began to lay down some physical infrastructure. So we acquired the land and began to plan Colony Park in collaboration with a neighborhood association there, Ms. Barbara Scott and others. We opened with CommuniCare's partnership 2 full-service clinics in Pflugerville and new pathways at Chalmers Court and the collaboration with the Housing Authority. We did a lot of eligibility work. Sendero met and exceeded its targets, which was fabulous. We began to implement direct methadone buprenorphine access, and I won't read through all these sections, but a lot of really good work, including direct care work, which is critical. And then as you roll up, coming forward to by the numbers, you can begin to see by the numbers the number of folks who received MAP coverage, MAP basic coverage, and some of that work around access and eligibility, which we know is a priority and will expand. And then you begin to see some of the service expansion that occurred sort of in a geographic fashion there. 155,000 patients served, individual patients in FY 2023, and 612,000 plus primary care visits provided through our broad network, including our direct partners and our contracted partners, Peoples, Lone Star, and others. A total of 247 provider locations, and an overall increase of our provider network by 12%. So just a few highlights there. And then finally, if you read through my letter, we're really, this is the year where we began a shift that was many years in the making, and I give great credit to Mike Giesland and the leaders before me, Chair Charles Bell, and many others, to recognize that our core responsibility is not only to pay for the care, but to ensure that the services are accessible, that they are delivered, and that the results of those services close those gaps in outcomes. I know we're going to talk about equity later today, but equity is about outcomes in care. If people are dying 10 years earlier east of I-35 or 20 years earlier in the most sharply disparate census tracts, then that is our job, to reduce that avoidable early death and all the drivers of it. It's not enough to pay for the care. We're going to go out and build the system and deliver the care. So this is the very first year that we began to do that in 2023, and I can't wait to report on 2024, which is coming up, and to keep on going together. So thank you for the opportunity.
Thank you, Dr. Lee, and I assume this is available on the website if anybody wants to see it.
It is. Copies in our lobby, and I really would love it if those who are interested have a chance to access it in all kinds of ways. But yes, we're getting started. A lot of work still to do, but I'm really proud of the team and the direction and vision that I've stepped into. It's really an honor.
Thank you.
Thank you.
There's no motion needed on this item. Does anybody have any questions or comments? And let's see, I can't, just a second. I can't see Dr. Musaitif or Manager Matwani, so let's see if they have anything. Do you want to go first, Manager Valadez?
I think Shannon had his hand up.
Okay,
first, and
Shannon, you
I'll
want to go
second.
first?
Excuse me. First, I'd like to congratulate the group on putting this together. This is very, very visual, very, very helpful, and very, very informative. And I agree with our chair that hopefully it's available online in the light.
Yes.
What I would encourage that we do is that we not only have it available electronically and for us, but somehow or the other we can go into the quadrants of Travis County, the municipalities, and other groups within those, and visually present when we have time, either at a city council meeting in Bee Caves or at a city council meeting in Jonestown or in Maine or and one, make this available. And second, emphasize this, because where we are quite comfortable with this, those communities that I've talked about are very limited in terms of their understanding of this. So I guess what I'm saying is, as long as we need to be in your face sort of thing towards that effort. So, and to the credit to Ted and his group, they do great outreach work, and I'm not implying that they're not, but I think we need to be, meaning maybe board members ourselves, need to be at those meetings and identify those, because we have to remind the public that on that tax bill, that this money that is coming now is coming from there to provide these services. And this is these are some of the results of those things. So I just want to emphasize that. Thanks for the report. Great job that you're doing, but I just think that we as a board need to be also more visible out in the communities doing these things.
I think that's a great idea. Let's follow up on that. There are a
Absolutely,
lot of
yeah.
smaller cities throughout Travis County that their constituencies pay taxes. And so, and like you said, Manager Jones, they're not aware of what we're doing and having the ability to show them that. So perhaps we can work with someone on staff to, maybe Pearl, would that be you? Okay, and then we can have board members go. And I think the council meetings is a good place to do that, because that has some visibility in those communities, and it can just be a, part of their citizen communication and report kind of thing.
Love it.
Okay.
Great suggestion, and we'll definitely follow up.
Okay, let's see, Manager Valadez, I think
Yes.
you were next.
And just to follow up real quickly on that, we have 17 school districts in Travis County.
Yeah.
17 school districts. I'm sorry. And what would be great is if we reached out to those school districts, because that's where the majority of the students are. The families are going to go to the meetings. They're going
Yeah,
to
that's
have
right.
teacher conferences. You've got all kinds of other staff within the school districts that can provide information, leaflets, flyers, whatever, to their families and communities. So let's not forget about them. And I'll start with here. I am one of those people that is concerned about the use of population health. I don't want a community, and I don't want the legislature to get confused as to why Central Health was created. We were created to provide for the indigent care, for the uninsured, those living underneath 200% FPL. And Austin Public Health deals with population health. And when I hear people banding about the term population health, we may have people get confused as to, well, we're supposed to deal with everybody. Well, we're supposed to make sure that, especially as we're looking at implementation of an equity plan and closing those disparities gaps, that the measure for whether or not we're successful is going to be how well we're taking care of those that live in our targeted population per definition. And so when we put population health here, I know there are some board members and people in the community who say, well, Central Health deals with population health. No, we do not. Overall, it's like, as you do to the least of my brother, so you do unto me. So that is where I come from. And that, to me, also, under the Constitution, is the general welfare laws. General welfare clause. But I think we need to really pay attention to that, and if we're going to do that, let's do that. I like everything else. When it comes to the accounting and dollars, what we do with your tax dollars, I just want, you know me, I'm going to ask, where is the money from that's in our reserve accounts? Is that hiding under unrestricted? Because we don't have contingency reserves and we don't have emergency reserves listed here, but that is an issue. And so when our public looks at, okay, you've got $450 million sitting in a reserve account, what are you doing with that? Why haven't we made MAP a 12-month program? You know, I understand the litigation issues as a result of the legal agreement with Seton. But there were a lot of people that didn't quite understand, and we did have some people that were negating that there was a 25,000 member and patient limitation. So as we deal with that and hopefully take care of that, that's one of the reasons BASIC is here in place. MAP BASIC is to enroll more people. I want to know where that money is. Where is the contingency and reserve? Here, I don't see it, and I want to see it. So I don't have to ask for it every time we do a financial statement. Aside from that, in looking at equity, and
Let's not talk about equity yet.
okay.
Let's focus on this.
Okay, and another, well, I guess I'll bring up my comments, because it was talking about our wait times and how successful we're doing in eliminating those, as a measure. I'll get to it during that discussion. Thank you.
Let's talk about that.
Thank you.
Okay. Okay, I think that what I'm hearing you say, Manager Valadez, is two things. The use of the term population health may not be something that people are familiar with. And so when they see that, they may confuse that what we're really talking about here is our population as opposed to population health in the community. So think about that, Dr. Lee, when y'all are using that term. And then the second thing is the reserve account for transparency purposes.
And contingency.
And contingency, it needs to be able to be seen. So, okay. Other thoughts, comments, anybody else? Dr. Musaitif, do you have anything?
And I want to thank the
Hi.
people for doing that.
Yeah.
Can you hear me?
Yes, we can hear you.
Thank you. Thank you, Dr. Lee, for that presentation. Really excellent work, all of you. Commend you on all your efforts. I agree with my colleague, Mr. Manager Jones, in terms of what he addressed in terms of outreach and simplicity of the graphs, and so I commend you on that effort. I have 2 points that I would like to address. One, can we make these reports available in grocery stores, places that are accessible? And I believe it has been done in the past. You may have been doing it, just in making sure we're at high-touch areas where our population is to make it more accessible to them. Second thing, I just want to highlight in terms of population health, when folks talk about it, there is a confusion, but we need to think of the larger scheme, what it means. It does not primarily only mean public health, but in my terminology, population health is bridging healthcare with public health and how we can overall improve the health of our communities. Because as you all know, our community's needs are greater than the clinical walls, and we need to address the barriers that pertain to our population. So I am just going to leave it at that, and I will encourage us all to look at more streamlined definitions and terminologies that has been used across different health systems. Thank you.
Thank you, Dr. Musaitif. And I like the idea of making this accessible in places people go, whether that's the checkout line, someone will explore that. And in Case Health, I'll offer one other potential way to think about population health, and it may not be the right term, but sometimes we think about care that focuses on whoever comes into us. So you made an appointment, you came in, you actually made your appointment. That's one kind of care, direct care. But there's a lot of folks who weren't able to make it in, or for various reasons, they didn't show for that appointment. And we want to make sure that we see them too. And we engage, we outreach, perhaps we go mobile to make it more convenient. We change the language providing the care. We make sure the person providing the care is trusted. And so in my mind, this is the distinction between a focus rather than who comes in and versus a focus of the entire population that needs us. Our population, Manager Valdez, who's under 200% poverty limit and indigent within our county, but whether or not they present for care, we need to go and embrace the entire population. So that is what I mean when I say that. But I understand that it is a term that has been used in different ways. And so we could think about different terminology to address what I mean, but I wanted to at least share that view with you. Thank you so much.
Okay. Let me see if there's any other comments first. Any other comments? Okay, go ahead.
So I look at that as community health, okay? We have population health that's been given by law, has a definition, and where the responsibilities lie for taking care of everyone's population, specifically for us under Chapter 281, it was defined legislatively. And so if we're going to talk to that, that's one of the reasons I always like the idea of community care, because community care is exactly what we're supposed to be providing. So if we start looking at it in terms of community, then let's talk about community health and the health of the Travis County community and all those that we impact. Thank you.
Thank you.
I just wanted to.
Go ahead,
comment. I think this is a very important discussion that we need at another time.
Right. Yeah.
One of the reasons I use sometimes population health and our population is that our population is in and out of eligibility throughout the year. So the question is, if when they're part of the eligibility, are they our clients? And when they're not part of the eligibility, are they not our clients? So when I talk about population health, I globally, but I also concur with my colleague, Manager Valdez, is that we have a specific mission. And when we're doing what we're doing, we're addressing that mission, but recognizing that that person who was there in April, come December, he or she may also not be eligible because of other things. So I do think we need to have a conversation so that we're all on the same page when we use these terms.
Okay, that sounds like a good item to consider as part of when we have our retreat. So, because there's a number of definitional things that we'll be talking about as part of our retreat. All right, I think we're ready to move on to the next item. Okay, item number 3 is to receive an overview of Central Health's approach to healthcare equity, along with a proposed definition, and Sarita Kroc-Leach and Dr. Jewel Mullen will be presenting. And managers, there's a lot of really good information, really rich information here. I'm going to ask that we go through the whole presentation, and then we'll start. Then we'll open up for conversation and comments and discussion.
Thank you. Good afternoon, managers, Pat, and colleagues. We're going to start this presentation with the definition of health equity. If we can advance to the next slide. And generally, health equity is defined as a state in which everyone, regardless of their demographic attributes, such as race, ethnicity, gender, socioeconomic status, physical ability, body size, and housing status, etc., has the opportunity to attain their highest achievable standard of health. To accomplish that, we must prioritize efforts that identify and address disparities in health relative to those demographic and geographic attributes. And to focus that lens a little further, let's discuss health equity in the healthcare setting. And that definition, paraphrased from the Joint Commission's statement on healthcare equity, is that everyone should have access to safe, high-quality healthcare, but we know that disparities in care and outcomes persist for Black, Indigenous, and other people of color, people with disabilities, people living in poverty, and other historically marginalized groups. So how do we set out to achieve health equity? We ensure access to a high-functioning continuum of care. We set targets to ensure quality standards are met, making sure to disaggregate metrics by demographic and geographic attributes to identify those any disparities, to get to their root cause and mitigate when possible. We provide a meaningful experience for our patients and members, making sure they feel heard and accompanied through their care journey. We do this by holding ourselves to certain standards of interaction, checking our implicit biases, delivering care that is compassionate, engenders trust, and makes people we serve feel safe in our hands, accompanied and empowered to advocate for the outcome they seek. We start by cultivating that ethos of Central Health, but set an example and set that expectation of all the teams who care for our population. And of course, we do this in a way that doesn't result in staff burnout, as that would be counterproductive to these goals. And finally, we have to identify, document, and collaborate with community-based organizations to help address health-related social needs, such as food, housing, transportation insecurity, as well as the lack of other basic needs. Utilizing CHWs to help our patients engage with the CBOs, providing access to those needed resources. Next slide, please. And how and where do we focus our efforts? This is Central Health's Healthcare Equity Strategic Plan Imperative. And it emphasizes access and capacity, which means ensuring we have the capacity to accommodate clinical demand, ensuring multiple access points, whether at a physical location, virtual care, or care at home. It also emphasizes coordination supported by a data infrastructure that allows patient information and care plans to be easily shared between care teams. Member engagement, making sure we're not excluding hard-to-reach populations from care, and as previously mentioned, making sure our interactions with our patients are culturally appropriate, free from prejudice, and engenders trust without being patronizing or pathologizing. And finally, providing a continuum of care for our patients, contracting and collaborating with other healthcare organizations such as hospitals, ambulatory surgical centers, SNFs to provide that care, and setting expectations as to the standard of care being provided. Again, the ultimate goal is not just to provide care, but to ensure the quality of care meets high standards. Next slide, please. And how does our healthcare equity plan help close those gaps? Most of you have seen this stoplight chart. It illustrates the access and capacity that has been and is being built to ensure access to multiple specialties, diagnostics, care for special populations, and care coordination. Next slide. And on this slide, we're focusing on an example of how we collaborate to provide a blanket of care that goes beyond clinical. As you can imagine, in addition to their clinical needs, our respite population who are unhoused have numerous health-related social needs that have a significant impact on their outcomes. They don't have access to basic necessities. In the respite setting, our CHWs have the opportunity to accompany those patients through their journey, collaborating with social service providers and other community-based organizations who can help navigate those patients to services and address basic needs in addition to getting them on the road to permanent housing. And then, of course, we can measure the impact of those interventions to understand where we forge more robust collaborations that meet our patients' needs and result in long-term health benefits. Next slide, please. And so we've talked a lot about quality up to this point, so let's focus on how we ensure it. We set standards referencing those set by various quality agencies and organizations such as the Joint Commission, NCQA, and others. We cultivate a culture of compassion for the population we serve, providing care that engenders trust, is free from explicit or implicit bias, empowering our patients to advocate for their own health and well-being. We foster a culture of continuous improvement, learning, and innovation to improve the care we provide and the processes involved in that care. We identify barriers to care and collaborate with other healthcare organizations or community-based organizations to address those barriers, whether that's access to clinical services we don't provide or access to basic needs such as food, housing, and transportation. And we focus efforts on processes that drive value for our members and patients. And finally, we measure the impact of the work we're doing to understand if it translates to better health outcomes relative to targets that define better. And we seek patient, community, and staff feedback to understand how they're doing from their perspective and how we can improve. And as always, we disaggregate to identify disparities in those outcomes. Thank you. Oh, and finally, one more slide. So to summarize, Central Health plans to achieve healthcare equity for residents in Travis County with low incomes by increasing access to high-functioning system of care that includes collaboration with other healthcare organizations and community-based organizations, ensuring care quality and long-term positive health outcomes by establishing metrics and setting targets relative to standards to be achieved. We also want to make sure to disaggregate those metrics and relative to demographic and geographic attributes to identify disparities relative to performance or outcomes, and creating long-term positive impacts to health by collaborating with CBOs who can address our population's health-related social needs. Thank you.
Could you go ahead and let people know what's in the appendix, just to point
Sure.
them to that?
And in our appendix, you'll note that there are several graphs, charts that illustrate some of the disparities that we see here that are related to health disparities, impacts on health disparities, from health disparities in Texas, and specifically Travis County. And did you want me to go through each of them, or just let people know that they're there?
If you don't mind, just brief, so people know what's here.
Sure. So this first chart that you're looking at showed the economic impacts, as it says there, of health disparities in Travis County, in several counties in Texas, including Travis County. So you'll see that relative to those, the cost of care or the productivity cost that result from healthcare disparities, Travis County comes in 5th in terms of what it's costing the county to care, because the care that's rendered isn't, because there are disparities in outcomes in that care. And then the chart below shows, again, productivity costs per capita. So for each person, for example, that disparity in health results in about $223 per person per year for the population. Next.
May I add
Yes.
a footnote to that comment? Thank you. Okay, thank you. I just wanted to add the footnote that those two charts are a reminder that health disparities cost everyone. They're not just a cost to the people experiencing disparities. And given the earlier conversation around the importance of having everyone in the county understand the importance of this work, I think that underscores that point.
Okay.
Okay.
Thank you. And this next chart, again, translates those disparities into the years of lives lost and what that translates to in terms of a loss of productivity that results in an economic deficit. And the next chart. And again, this shows those years of lives lost, disaggregated by race and ethnicity relative to the different measurement years here. And you'll see that, compared to other populations, folks who identify as Black relative to race ethnicity tend to have more years lost, of lives lost, because of healthcare disparities. And then the next chart is one that there are two charts here, and you're all familiar with these from our demographic report when we disaggregate our outcomes relative to different chronic illnesses, and we look at it relative to location and by race ethnicity. And you'll see again the highest impacts. Folks with the highest prevalence tend to live in East Central Austin and Southeast Austin, and more than any other population, our Black population, white population tend to have more instances, higher prevalence of most of the chronic illnesses that we've selected to examine here.
May I just interject a question?
Can you wait, let her finish, and then I'll get to you first.
Okay, I was just trying to make sure we understand the context of the data, that's all I was asking.
Yeah, that'll be your first question.
Okay.
So, anything else that you all have?
There's some other definitions that you all
Yeah,
can
we'll get right
peruse,
to it.
but
Okay. Go ahead.
so these are just definitions of health equity from the World Health Organization in 1946. And I'm not going to read them out, but they're here for you to see. And, I provided a summary or a synopsis of all of them, really. There's one from the World Health Organization, the CDC, and DHHS. And then finally, there's if you go to the next one, the definition that I paraphrased earlier from the Joint Commission that speaks to healthcare equity. And that's it.
Okay. Dr. Mullen, do you want to answer? Do you want to add anything before we go to questions?
No, thanks.
Okay. All right, Manager Jones, would you like to start us off?
Yeah, first of all, I just have a question. When we're talking about this data, we're talking about the entire population. We're not talking about just MAP clients.
For the data that we're looking at,
Potential life lost,
right, those are Travis County populations and they're the general population.
right.
And,
Go ahead, I'm sorry.
and we could potentially do this analysis specific to our MAP population.
But my point I was trying to raise, and goes back to my comment with regards to, brother, is that these people are, some are MAP and some are not. They're in and out of our MAP eligibility. So to the degree that we're able to impact their health outcomes, we impact the health outcome of everyone. And so there are some folks who have private insurers, they get laid off, lose their job, and end up having to get, during the time that they're with us, then they're our clients, and we have an impact. So I just want to emphasize when we're talking about central health, we are a public health provider, but we have a targeted group within that, and that targeted group changes from day to day, perhaps. And I just want us all to be on the same page and understanding that, if I'm correct there. Is that a fair statement? I mean,
You're
I'm open to comments.
absolutely correct, Manager Jones. And to underline that, you can see, we know the disparity east and west of I-35 is 10 years of life expectancy, 20 years in the sharpest census tracts. And then we see in that chart you just held up that the real disparity there appears to be in our Black community. And we then know furthermore that within the homeless population, 8% of our population is Black, 40% of the homeless population is Black. We look at the folks who have the longest length of stay in our Travis County Jail, and something approaching 40% of that population is Black. And so when you begin to drill down these disparities, we see where that sharp inequity lies. And not to say that we are only focused on our Black population, but the data are speaking to us that there are pathways here that we want to change the way that things happen so that we change the outcome. And yes, I think we have a responsibility to improve the health of our community, our whole community. And if folks are dying earlier than their time, and we have the privilege of serving them, then that is our privilege.
Okay, and then just one other. On the Exhibit 1, what we're talking about, this is the productivity cost of health disparities. I guess my question is, what we don't have here, and I don't know if it's reflected here or someplace else, the per capita cost, and maybe this is here, of the major metropolitan counties in Texas and where Travis County fits versus those. Because what I understand is that our per capita cost is less than our other major components, major counties. And that's something that we need to address, or we need to at least talk about. And I didn't know if you could speak to that as well. And a lot of it has to do with what we do, how we do it, and who our partners are. And to the degree we talk about that, we need as a board to talk about how we are providing our services that result in this type of outcome or these types of outcome. And I think there's a correlation. We can have another time, but I just raise it at this point.
Yeah, if I may, Dr. Mellon?
Your point just prompts me to go back and look more at the analyses that the Episcopal Health Foundation conducted to be able to address that fully. That's where these came from.
Right, these came from a specific report, and they just reported the top.
An outside agency.
I believe the Episcopal Health Foundation and St. David's Foundation were two of the major funders of this report that was called the Economic Impact of Health Disparities in Texas, and went through all the counties of Texas. And you can see the excess medical expenses resulting from health disparities. You can see the lost economic productivity resulting from health disparities, and then the lost years of life resulting from health disparities, all of which translate into kind of apples to apples, dollars and cents. And the sort of takeaway numbers that for Travis County each year, the total is about $1.1 billion, and that was in 2020. That's a pretty big number, $1.1 billion. And so as we do our work and we drive down that inequity, we will begin to deliver millions, maybe tens of millions, maybe hundreds of millions of dollars of that value back to the Travis County community. We are publicly funded, and we are ultimately accountable to the public, and the public pays one way or the other. If we do our work well and folks get prevention and primary care and are healthier and happier, they are also going to spend less time in the jail, less time in the hospital, less time getting expensive, unnecessary care that could have been prevented. In the end, the public will pay less for much better care, much more fair care, much more compassionate care. And that is our responsibility and our privilege.
I want to, oh, go ahead.
But I can discuss it later to get other folks.
Yeah, I think there's a lot to talk about here. So let's stay on the topic of these numbers for a minute so that everybody can weigh in if they have something they want to say on them. And then we'll raise other issues. So I have some comments too, which I'm just going to lay out there right now. I am hoping that we will get to the point in the future so that we can drill down to the population that we're serving.
That's right.
And so we can have data specific to our population so that we know what that is. Now, I raise that because I'm not certain of the status of our data right now. I'm assuming that the status of our data right now doesn't allow us to do a chart like the prevalence equity index that identifies the disparities, this one. It would be fabulous if we had this chart by our population. Now, I realize we probably don't have that data right now,
So
but
that
I
is-
hope that's what we're working towards.
Yeah,
'Cause
that is actually our chart. That is actually our population. We
oh,
have it in
great.
our demographic
All right, so
report.
this is not Travis County as a whole.
Right,
It is
this
our
is
MAP patients.
MAP and MAP basic.
Okay, so this is MAP and
charity
MAP
as well.
patients. Okay, great. That's wonderful.
Does it say that?
Yeah, it needs to, we need to be a little clearer on that.
clear about where this information
Sure.
coming from.
Yeah.
And that is on me because I've seen this so many times in our demographic report and I'm constantly referencing it. So I assume everybody knows where it's from, but I'll make sure I do that in the future.
Okay, yeah, that would be very helpful. So Dr. Lee, when you're talking about what we need to focus on, I assume that this kind of thing is what's driving us.
Absolutely. I think we would love to both label this properly, but also send to you the demographic report from last time.
Yeah,
And I'd actually would add to that, what do you need to see in the demographic report? Because the demographic report is both very powerful as a way for the public to see what we're doing, but it's also very powerful as a way for us to see what we need to do. It is at its heart, a strategic planning document, and we are in the process of actually formulating the questions for the next demographic report. So I'd actually welcome all of you to spend some time with the last one, and then give us some ideas of what you need to see in the next one, because we're literally in the year-long process now under Sarita's leadership and others to take us there for the next version of this.
well, let me just ask then, let's talk about what this means here. So when I see a line that says, the relative risk in Colony Park for asthma is 0.9, what is that? Is that telling me that we know that because we know our population that has asthma in Colony Park?
So these values, when you see a value that is equal to 1, it means that the prevalence rate for that population is where we might expect it to be compared to the general population, the overall
Okay.
population.
Okay,
If it's below 9, then they're faring a little better.
Okay.
If it's above 1, then they're not doing as well.
Okay.
And the degree of the disparity also, it can vary. There's additional statistical analysis that's done to identify which is actually purple versus gold, and the gold, they're usually faring better, the purple, they're usually faring worse. And yeah, the higher the number, the greater the disparity
Okay.
compared to the general population. The higher the number above 1, the lower the number below 1, the better they're faring compared to the general population.
okay, and it's based on diagnosis for our
Yes,
patients?
there are documented diagnoses that
Okay.
we see in our patient charts.
Okay.
And which is what, I know the next question usually is how does this compare to benchmarks? And that's always a difficult thing to gauge because most of the chronic illness information that we get come from self-reported diagnoses. So a patient might fill out a survey that indicates that they have heart disease or COPD, et cetera, which isn't usually the most reliable way to capture this. And we understand that in some instances, there may be an underreporting of prevalence because of the lack of access some of these patients might have to the care to diagnose them with that illness. So again, it's a little tricky. The Burfus data, they're sampling, it's a relatively small return that they get. Burfus is the survey that is disseminated to ask people about their health, the general population about their health. And when if you were to go out and look for prevalence relative to Travis County, because of the few surveys that come back, the data doesn't often get disaggregated to that level where we can really look, because the numbers are so small that you wouldn't really be able to say that there's a meaningful difference between outcomes in those groups.
So this is based on this data on
This
this
actual
show?
data that you're looking at here, which is our central health data, is based on documented diagnoses. So we're
From medical records?
yes,
Okay, it's not survey data?
right.
Okay, okay, all right. Do we have those kind of medical records for most of our patients?
We do. We have
Okay.
diagnoses for, we try to get as much as we can. We source all of our data sources for those diagnoses.
Okay. So we feel, so this kind of data covers all of our population, or are we missing data, do you think? I'm just trying to get order of magnitude.
Sure. So, they would be data for utilizers. So if we
Okay.
have members who don't utilize
Right, if
the
they're not
system,
utilizing,
whether
then
they're
we need-
children or,
exactly.
they probably wouldn't have a documented diagnosis.
Okay. Okay.
Because we're looking at chronic
You want to go
illnesses,
ahead?
Is this our patients? These are MAP patients.
MAP and MAP Basic.
MAP and MAP
charity,
Basic.
Yes.
Is there any comparison to this data to the other population? So we can see whether or not our numbers are higher or lower
So
than the
that's what I
other?
was just speaking to. It's hard to find that comparator, because, and we've looked at it, and it's the differences are really, they don't make sense in that, again, those data that are coming from the publicly available information, they captured via survey. Patients are reporting their diagnoses. So they're identifying whether they have a cardiovascular illness or COPD or behavioral health issue. And then we can't narrow down to our specific population in Travis County either. So we
Well,
wouldn't have that.
the reason I ask this, and forgive I'm raising the public health aspect of this, is that data is collected from death records. And one of the questions is, as an indicator, obviously not as an absolute, but as an indicator by areas, are we able to look at the data that we have from our clients and the data that they have for mortality, which is a finite data, to see if there are any trends to be able to ascertain, do we see trends in terms of the population that we serve and our interaction or intervention by our service delivery in that area? If that makes sense, I'm not sure.
Yeah, and mortality data, again, it's I think, Manager Jones, we've talked about the difficulty we've had in getting mortality data specific to our population. We have to go through the IRB process with DSHS to get those data. We went through the whole process, and then we were denied access to those data at that level. APH does not have, it's all de-identified, so we wouldn't be able to understand if it's our population.
But APH has the data for the county, and all I'm saying, taking our data, comparing it to what APH has,
And
and see
you're
is there
doing,
a
again, what Manager Valadez just said that we shouldn't be doing, and that's comparing our specific outcomes of our population, and especially to the overall county, right, regardless of socioeconomic impact. And again, when you're looking at these data for the entire county, and if you, can we bring the chart back up that we were looking at for the prevalence equity index design? So you lose sight sometimes of what's really going on when you focus that lens in on our population to figure out like where people are impacted. So you might not see places that in our population, it's previous to that. In our population, you may not see because of certain areas in Austin that are gentrified and have folks who are living in extreme poverty right next to folks who have houses that are $500,000 or more.
No, I follow you there,
Yeah.
and my only question goes to the fact, is there any way to look at trends, not fixed data, but trends of what has happened with our population and what's happening in the general population over time to be able to see what's going on? And I just use this as an example. When I first came to Austin in 1999, zip code 78702 had significantly high mortality rates. If you look at that data today, you're not going to see that same kinds of things. And the question is, and our population still there. It's a smaller number, our meaning MAP, but the other general populations has changed. And that's occurring all throughout the county. So I'm just trying to see if there's any way we can look and see, are there intervention methods within our populations that are impacting the general population as well, for what it's worth. I'm sorry, I don't mean to belabor.
No,
that's
go ahead.
My epi background, so forgive me.
Sure. Well, no, I think your background is helpful, so that's why we're.
Okay, well, I'll just.
Sure.
May I just ask for future consideration, whether or not you would be interested in that just by neighborhood or zip code, or are you thinking about more aggregate data that could come from sources like Medicaid or other payers as well? I'm just trying to get an idea of the kind of comparisons that you might want to have to look at different trends.
Well, I think, this is just me, but I think that it would be helpful if we could see, I'm sorry. If we could be able to look at a variety of categories in which we can look at, so that we can see trends based upon those factors. And I think working with APH, you might be able to help, that might be able to be a collaborative effort you all might be able to work on, but that's my feeling.
I think this is exactly the direction, Manager Jones, that we want to go in our next report. We recently met to think about the questions you want to ask, and I asked almost the same questions you did. Mortality, certain index health outcomes. So I think we're going to work toward this, and I look forward to understanding the limitations of what we can and can't do, and which comparisons we can and can't make, and whether they give us a relevant view. But I think you're right. We want to know what's happening, and if we intervened, did it make a difference? So we're on that, and hope for the next iteration we'll get closer to the view that we need. Thank you.
Thank you.
Okay. Other questions? Go ahead.
Comment. Am I on? Yeah. Pardon me. The last slide you have, proposed definition that you had, this may not be the time to discuss it, but one of the things that, pardon me, I'd like to see added, and maybe this is part of, I'll leave it to the Madam Chair to determine this, but perhaps this is also part of the conversation that we will have at our retreat, because I think that we need to kind of flush this out to make sure we're all on the same page. So with that being said, I'd like to have a discussion or see if we can't insert the words where a person lives, because that really impacts the definition of health equity. I mean, yes, we assume that because of your economic, social, mental, physical status, you're going to live in a certain place. But that's not necessarily true, as mentioned already in this previous conversation about the data, because we have, we've changed so much as a community, and we still have a rural area in our county that has yet to be addressed, or that we're trying to address, but I think that too will further support our efforts with those people that fund us. Further, one more thing, as I was thinking through all this conversation and discussion, going back to, not to over address this, but going back to population health definition, I think that too will help us further define this whole definition of health equity as we look at the two. So I'm just throwing that out, putting that out there.
And I think also we can talk about next steps for this definition. Whether we want to bring that to the retreat, perhaps, or whether we want to suggest these changes right now and go ahead with them, and then think about how and when we're going to use this. Dr. Lee, do you all, and all of y'all, do y'all have some thoughts about the proposed definition and what we're thinking in terms of the next steps for it?
I do have a thought, and I don't know if this is right, Chair Kitchen, but I've seen a lot of wordsmithing around definitions like this.
Yeah.
A lot of effort can be spent getting the adverb just so. And for me, I think as Manager Valdez knows, that's where I pushed actually to move that definition to the back of the deck and to move this to the front of the deck. It's got a couple of bullet points. Everyone has access to safe, high-quality care across the continuum, period. Right? Groups that have historically had worse outcomes, we narrow or eliminate those gaps. And that we address root causes and we drive to objective quality standards. So these are the core elements that we're talking about.
Okay.
And so we can definitely put that into succinct sentences. But for today, we wanted to stay focused on the prize, which is really getting those services out and holding ourselves accountable to the outcomes. And this is an outcome-driven approach to equity. And I think that's the underlying point that I'd want to get out there and have us all see if we agree, and then have us all out there on message so folks can recognize that that's what we're driving toward. That's our responsibility and our privilege.
Okay. I do think it'd be helpful at some point to, and I like the elements concept on the first page. So whether it's elements or a more traditional definition, I do think it'd be helpful if we're all on the same page. So, so that might be an item for our retreat, that we come out of it being on the same page, not to wordsmith, but just to make sure that we have all the elements that we want to make sure. And since many of us are here, but not all of us are here now, and this is our first conversation about it, we can begin thinking about it, but maybe bring it home in terms of the scope of it as part of our retreat. Does that make sense to you?
I love that. I think us all being on the same page on what do we mean by health equity and how does it connect to what we do and the direction that you all set for us to do, I do think is critical.
Okay.
And wordsmithing, we can certainly do it if we think we need to, but I've seen a lot of time spent on that, and I think we want to spend our time transforming the care. But yes, we absolutely need to be on the same page. Agreed.
And I do think it's helpful to think what we mean by everyone, because I think the point that Manager May was saying is important, because
Yes.
often when people say everyone, they have different things in their heads.
What's everyone?
What they mean by that. So at the risk of spelling out every word, it is important to have a little more detail, I think.
Yes. I love that.
Okay. All right. Let's see, do you want?
Just to your question to Dr. Lee, I agree with his response and offer you a both end addendum, which is that at your retreat, as you consider whether or not the definition, which might be just adopted for a standard definition anyway, is all encompassing. That final slide that says healthcare equity is achieved could be tweaked a little bit to represent sort of the vision for people that Central Health is serving. So there could be a place for both, because my impression is that this conversation reflects that statement at the end is, just representative of the work that you're supporting and that Central Health is doing. So there's value to it as a reinforcer, but I'll stop there.
Okay, thank you. Manager Valadez, you want to go next?
Thank you. Historically, we know that those that access services the least, aside from being men and men of color, are people who don't have status. Okay? And we have nothing in here that talks about how we're going to disaggregate the data. When we talk about Latinos or blacks or anybody else who is actually able to access services, because everybody denies them for anything. You can't get food stamps, you can't get housing, you can't do this, blah, 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 because you don't have any status. And yet, historically, Central Health has never identified, and I appreciate that they don't take status into consideration, but for the purposes of identifying a demographic and how really bad off I want to say newly arrived as opposed to immigrant, the newly arrived population is. And even those that we have immigrants that have been here for 50 years, 60 years, they've got generations of families here, and they're still under that definition legally. And so I'd like for us to break that down if it's at all possible, because I think that talks about the development of a specific strategy to reaching that population, which may or may not speak English by now, are or are not literate. They come from different countries. They never participated in an educational system. What the heck are you talking about when you talk about equity? What are you talking about when, I can remember as an advocate for special ed, and we'd go talk to parents about their children in special ed, and I'd talk to somebody who spoke Spanish and said, es que mi hijo es muy travieso. you know? As we said, I said, what are you talking about? The guy had ADHD, he had this, he had behavioral issues, he had emotional issues, blah, blah, blah. Forget the fact that he lived in poverty with no access to resources. So I think it's really important that we start looking at that population also. And at least understand what we're dealing with in that,
Challenges, yeah.
in that area. And so I just want I want to throw that out there. Aside from the seniors living in poverty, I just want us to consider that, because I think that's a big number. They're the ones that are working or not working. When you're talking about your impact on the economic impact, they have, who's building our buildings? Who's painting your walls? Who's doing this? Who's in the houses? Blah, blah, blah. Okay, so who's building our streets? Who's building our communities? And yet, they're not considered. And I want to make sure we elevate them to the same standard as everybody else. I don't like them to be a first or a second level tier of a person, a resident. So I just want to add that. And then I do have some suggestions. Whenever we get to a point, I gave Ann something thoughts that I had put together, and I'll give it to y'all to look at. I gave Dr. Lee a copy, and I gave Ann a copy. She's our chair. But I'd like for y'all to have it. And if you want to distribute it to the board members, just to, maybe they can start writing their little comments for us to consider, especially as we look at next steps. And maybe what we need is to look at the Joint Commission. They have a certification program. Are we going to join it? Are we going to be a part of that? Are we going to adopt those things? Because if we're talking about that's a standard, well then let's reach that standard, okay, as we try to make us the best model for the delivering of services to our population in order to close those disparity gaps. Thank you.
I'd like to take a minute and talk about those suggestions that you made, Manager Valadez. I think they're all good suggestions. I want to run through them real quick, if that's okay with you.
Yes.
Okay, the first one relates to something we've been talking about, which is the definition. But just to add the point that you made in your work, in what you wrote, which I kind of think we've been talking about, but let's really point it out, and that's that equity is a quality of care issue. So thank you for writing it that way. I mean, basically, as you said, Dr. Lee, we're talking about outcomes. So we're talking about quality and outcomes for our population that is, equivalent and equal to the rest of the population or better. So that, because to me, a disparity, and one of the key things about disparity is a difference in the quality of outcomes that people are experiencing, and so we want to address that. Second thing you just talked about a minute ago, I would like to understand what our next step is on seeking the Joint Commission's Health Equity Certification. I'm probably not using the exact words that they're using currently. And there are a number of them. There's JCO, there's other things. I would like to understand from you all what your recommendation is on a path to achieving that. That takes a while, and there's a path for it, but and it may take some funding. It may take some assistance from from someone who's a consultant. I know that our team, that you all have a lot of things on your plate. But I personally would like to see us say what that path is, rather than something that we might address in a year or two. I'd like to say right now that our path towards achieving certification, I'll just use that word, certification for health equity, that we are going to, right now, as part of this budget process, we're going to decide what that path is. That path may mean we achieve it in a year or 2 or 3 or whatever it takes, but that we're on a path for it, if that makes sense. Okay. Second, the last thing is something I'd also like for you, Dr. Lee, for you and your team to consider, and that's creating a chief equity officer position. I think that that's going to be particularly important as we grow. Everybody on the team is concerned about equity, and everybody's got that top of mind. Everybody incorporates that in what they do, but having a person who's charged with being a team leader on that for the whole team is important. And that can be a person that can help you, Dr. Lee, as you work towards that, as well as everybody else. So that's just a request that you think about that, and maybe think about it as the next budget process and let us know where you land on that.
Absolutely.
Does that make sense?
It does make a lot of sense. All the suggestions make sense. And I'll share something that Manager Valade and I reflected on earlier today. Okay. And again, this may not be right, but I'll lift it up. If we define health equity and our focus in terms of the outcomes that we achieve through the care that we deliver and the acceptability, accessibility, timeliness, and so on of that care, then I would offer up that the E in my title might stand for equity. I am the Chief Equity Officer. Our entire focus is on doing just that. Every single executive in the organization, every single person, that is the fiber that connects us. And so there may be an additional heft and lift that someone with that exact title designation may bring to the team. We should think about that, what is needed, what is missing. For example, I think a Chief Transformation Officer might be really helpful this time. But I'd like to think about it in terms of what does our team need to get to goal. But I see my primary work as equity, as defined, as change of the outcomes on the ground for with our community. And I'm open to everyone's thoughts on that for sure.
Okay, well, we can talk about that more, but I see that, I don't see that as an instead of, I see that as a resource.
Sure.
And I also think that it's a big enough job that you can't do that by yourself. Not everyone can do that. And I also don't see everything we do as equity. Because I mean, let me put it this way. That's not quite how I meant it. I mean, everything we do is equity, but it takes a targeted focus on additional things that we might do to really get to interventions that are going to impact equity. That's a lot of work. Yeah. And it's over and above what we're doing on access. You guys are doing so much in terms of building access. And but there's more to it than that. And I know y'all know that. I mean, I'm not saying anything you don't know. I would just invite you to think about it. It's also another way to point out to the community. So it's not so hard for the community to understand the focus on changing outcomes for people of color, low-income people no matter where they live in the community. Sometimes it's easier for people to understand if you're using the terms that they might understand, as opposed to the messaging that that we all do that. So I don't know if that makes sense. So I would just think about it. I mean, that's your, the board's not here to tell you how to organize your team. The board's just here to make some suggestions. So
appreciate that. Thank you.
Did you want to say something?
Just one final thing. When I first applied for this position, which I didn't want to do, and that's why my application went in at 4:59 when it was a 5 p.m. deadline on the last day. But everything had to do with lived experiences to get a true understanding of the population that we're supposed to be serving. And it's very difficult, to advocate for an agency which is not reflective of its population that's supposed to be serving from the top down, just like from the bottom up. People tend to look at the importance is looking at the bottom up. Oh, well, we've got all the frontliners, that may be able to communicate with you, but it's not that. Policymakers have to have that background, that understanding, that lived experience to be able to truly internalize what is meant by an advocate and what is meant by process changes that will impact the quality of life for a population that has historically not even been allowed one. So I just want y'all to, I think that's what we as board members advocate for, but it doesn't always mean people are going to understand that that's what we're talking about if they haven't lived that life or walked in those shoes. So, thank you.
Thank you. Let me turn now to the folks that haven't, Dr. Musaitev, do you have anything that you would like to add? And I don't know if I met, if Manager Montwani is still with us. He dropped off. Okay, Dr. Musaitev, do you have anything you want to add? And then Dr. Martin, if you have.
Well, thank you. I want to thank you all for that presentation. Dr. Mullen, Sarita, appreciate all your hard work. Thank you so much. I just want to touch base on one thing. I believe Central Health's mission and job is to embed health equity in everything we do. So it's not a sole responsibility of one individual, one person. So that is just, and we can touch base on really the terms of, I know there was proposals of perhaps hiring a health equity officer, but I encourage us all to look at other organizations, what they have done and what that meant for them. So with that, health equity should be in every aspect we do, and I see it is. We're getting where we need to be, but it's going to be a long path. And that's really what I wanted to say, and I commend you all for your efforts, and I have to sign off. Thank you.
Okay. Dr. Martin, do you want to make any comments? Or?
Yeah, thank you for the work. I had a question. I'm not a public health expert, but it seems to me that the study you did about the neighborhoods, et cetera, I think the thing that unites our patients is poverty. And I would argue or suggest that perhaps that we have some stratification, because you can go 2 blocks here and there's people living on poverty, and go another half a mile and there's multi-million-dollar condominiums. And so I think that lumping it together by neighborhoods is not a fair assessment. And I argued also that by lumping where the poverty is, to turn to address to capture those people who perhaps are not in our system yet. But I think there's just, granted, most of our population is in the I-35 corridor and whatnot, but there are discrepancies in pools that's very small differentiations in 0.9 to 1.3, which we're calling significant. But within 2 blocks here, there's multimillionaires and people in poverty. And I just would think that it would be an additional stratifier for me to see the incomes and outcome, because that does correlate highly, as we all know, with race. And I think it'd be very beneficial for me to look at it. Thank you.
Okay. So again, even within those neighborhoods that we're looking at, we are focusing on those folks who are at or below 200% of the FPL. So it's not including, when we're looking at those prevalence, it's age adjusted, and it does not include folks above 200% of the federal poverty income level.
Sarita, why were those the neighborhoods that were chosen? And I think if there are folks who are new to the board since we released the demographic report, maybe if we could do a separate huddle on kind of what was in the prior demographic report, it might be helpful.
Right, and those areas were identified as areas where we saw, most of our population, and those areas with high densities of poverty as well.
Okay, before we close this out, other thoughts, Manager Jones?
Just 2 quick comments. One, I'd like to piggyback off of what Manager Valadez said earlier. I drove into Austin today, first time really deep into downtown. If you look at all of the structures that have been built just in the last 7 years since I've retired, and I said, who built these buildings? And they're not people who, for the most part, are making $50,000 a year. These are folks who are basically here, barely making it, and many of which are our clients. So I think we have an obligation to. So I just want to echo and compliment you on it, because someone's building, they're not just being thrown up. But the other point I wanted to make, and I don't know if now is the appropriate time to do it or not, but when we talk about equity, DEI. I raise that for this reason, and is that presently the University of Texas, as I understand, has said we need to stop that and is in the process of removing people,
They're firing
They
them.
already fired.
firing them. We currently contribute $35 million to the University of Texas Dell Medical School. The question,
Excuse me.
Let him finish, let him finish.
the question,
it's hard, let him finish.
the question I raise, and maybe that's where you're going, is that maybe we need to assess that ourselves. If indeed the state university system has said that that is not a priority for them, and we're a funding agency who says that it is a priority for us and we're giving you money to do this, then I think we might need to at some point raise that as a policy discussion at the board level. So I just mentioned that because I think it is a significant portion of our effort to address equity in this community.
30 seconds. 15.
Just a second. Okay, go ahead.
Especially in light of the fact that under deposition, we know that of that 35 million, they were also giving to the
Okay,
chancellor's
that's
office.
beyond the scope, okay.
The chancellor's
Okay,
office,
let's talk
not
about
the
that
medical
off-
school. So I just have to say that because that really
Let's talk
pisses
about
me
that
off. Thank you.
offline.
Okay.
Okay, all right, so, anything else? All right, thank y'all very, very much, and thank you, Dr.
Thank you,
Lee, and
guys.
everyone. This is our first, well,
Call to
I'm
action.
sure it's been discussed previously, but the first recent conversation about how we're approaching health equity and with the goal of getting us all on the same page. And so this was very helpful, and there'll be more to come. All right, thank y'all. Okay, let's see, I'm gonna
Good to
move,
see you, Dr. Mills.
I'm gonna move on to item number 4, which is to receive an update on higher education workforce recruitment. Dr. Shalsa will be presenting.
Good afternoon, Chair Kitchen and managers. Alan Shelsha, Chief Medical Officer for Central Health. As we energetically continue to build out our healthcare infrastructure, concentrating on moderate and significant gaps, for the communities we serve, we're doing that in an environment where workforce shortages, specifically in healthcare, are pervasive, whether we're talking about providers, primary care, specialty, whether we're talking about medical assistants or nurses. I think a survey of nurses about a year ago indicated that between 30 to 50% of nurses indicate that they are considering retirement in the next 5 years. So as we build out this healthcare infrastructure, we thought it was critically important to consider workforce development so that we don't find ourselves 5 years from now without folks to actually care for our patients. Healthcare delivery in combination with our HR partners started working on this initiative, I think about 9 months ago. This initiative is also in partnership with Austin Community College. We have onboarded our first cohort of medical assistants. This program involves 9 weeks of didactic education, which occur at ACC, and then 5 weeks of internship, which occur in our clinical environments. Central Health is funding the salaries of, started out with 10 of these 9 individuals in cohort 1, so they're basically Central Health employees. When our team opened applications, we got 41 applications in 3 days. And so they closed applications. We started with 10 MA students. 1 dropped out for personal reasons. And our first graduating class will be in June. So we will graduate 9 MA students, the majority of whom are from communities that we serve. And so if considering health equity or equity, we are providing an opportunity to fund individuals and help them through their educational journey, and then reinvest that cultural expertise and that mission alignment, in our care environments. We just opened recruitment for our second cohort. We got 49 applications in 3 days, and so that one was closed. All.
Pause this 1 second, maybe.
I'll sit here. We'll hold all of them.
We don't have anybody else on Zoom?
Just to say, that's called grow your own.
I think we have,
Yes, ma'am.
we have 3 people here.
Doing it for.
It's Lisa, me, and, oh wait, no, she's not on yet.
Well, when Hasib gets back, I think you can appoint her to the committee, which I don't think you have formally done.
Yeah, but that's, I have to take myself off because there's just 4 people on the committee. So, anyway,
Yes.
it's all right. He came
I'm
back.
supposed to be on this committee?
Oh, you will be,
Oh,
as soon
okay.
as I get that in writing. So, anyway. Okay, it's all right, no worries. All right, go ahead, Dr. Shalsa.
All right, thank you. For our second cohort, again, we had 49 applications in 3 days. We filled those 10 spots. Every one of those individuals comes from a community that we serve. So 100% of those folks.
Okay.
That cohort will obviously, graduate before the end of this fiscal year, and our goal is actually to get a third cohort recruited before the end of the fiscal year. Our teams have also been working on a community health worker program that will certify individuals within Central Health. As we continue to build out, we have a critical need for peer support, individuals and community health workers. And again, if we're able to recruit them in the communities that we serve, we meet multiple needs, especially it allows us the ability to step up the care for the patients, that we are serving and will be serving. The reason that we're curtailing the number of MA students is because our footprint is still pretty small. So we want to make sure that we can actually preceptor those MAs. And so as we build out, so we can increase the size of our cohorts. Lastly, we are now looking at what a nurse residency may be, so we can start focusing on nurses. And that's meant as a teaser. We'll bring back more information as soon as we've solidified what that means. That is it, Chair.
Okay, questions? Anyone have, Dr.
Comment.
Martin, go ahead.
Maybe we could get the medical school to prioritize enrolling local kids from the community to become doctors. I mean, I know they're supposed to do that, but since that's the focus, just all, thank you. It's a great program, thank you.
Thank you,
Okay. Manager Valdez?
Thank you for bringing that up. That was something we suggested to AISD about 30 years ago. Grow your own. So, at least 20 or 10 years ago, when we knew the medical school was coming, we wanted AISD to develop a program that would funnel them from the moment they entered the school year through elementary school, through junior high, through high school, to college and into the medical school, so that we would grow our own doctors. The same thing, grow your own teachers, grow your own whatever. That's the philosophy that's been very successful. If you ever look at Isleta, their students are graduating, they're poverty, they're our population, and they're graduating with double and triple dual language diplomas and going to the top. They do better than AISD and going to the top elite and Ivy colleges. But I have a suggestion for the promotora. If you ever wanted to hire someone who can train, there is no better standard than what Jill Ramirez did with Latino Healthcare Forum and the growth of the community health workers that she did. They performed the best, as far as I'm concerned, for our population. So I make a suggestion, but I congratulate you on the growth of this Grow Your Own, and that's where Central Health should be in growing its own. Thank you.
Thank you. Manager Jones, Manager May, any questions?
I don't have questions other than to congratulate you on it. I think this is a fabulous idea. It's definitely in the right direction. And talk about community engagement and really involving ourselves in the fabric of our workforce. This is really where it's at. Thank you for doing it.
Thank you.
Yeah,
Yeah,
go ahead.
yeah, just 2 point. One, I'd like to support what Manager Martin said a while ago with UT Dell. I mean, we really need to talk about that at another time, but I think that if we're going to invest, we need to get that investment back, and we need to measure it too. The second thing is incorporating, or did I understand you to say, forgive me, I had to step out right quick, but are we looking at our own clients as part of this effort to recruit and to train? In other words, we have individuals, or did you say that we're utilizing them as part of that effort as well?
I did not say that, but I think that is one of the considerations in the future. We have been recruiting in communities where we serve individuals. Some folks may be our patients. Again, we haven't looked at that, protecting kind of them as patients. But where this is really important is when we look at justice-involved individuals, when we look at addiction disorders. We've had some conversations that the best way to have peer support individuals really support our own communities are folks who have gone through those experiences. And so while that was not a goal of our MA and our CHW and potentially our nurse residencies, it is something we're talking about so that we may in fact take that next step in the future.
Really, I just mentioned it because I'm familiar with the program we had at APH that might be, it's called MIOP, Maternal Infant Outreach Program. And these are women who have gone through the pregnancy, and many of them are job looking and have interest in health care. And I'm just thinking we might want to look at other programs that have clients that are part of our network as well to recruit and get into a training aspect.
It's a wonderful idea. We've had conversations with folks at Hungry Hill. I think as soon as we started entertaining this idea, every environment that we step in when we do community rounds, there are opportunities and individuals who are interested. So, we hope to continue to expand this and then reinvest, I think, that expertise within our environment. Thank you.
I have one question,
Yes,
and I echo what everyone has said about this is a great program. Do you feel at this point that the size of the program, I think I heard you say the size of the program matches your ability to place folks? Is that what you're saying?
Exactly.
Okay. And so are you anticipating growing the program as Central Health grows? Is that what you're thinking, or?
Actually, let me restate that. The size of our program actually is limited based on the ability to precept the students.
Oh, okay, not place them, but to precept them.
Not place them. I think as we, jointly develop and educate these individuals, whether we recruit them and they stay within Central Health, whether they stay within CUC, this is a system build.
Okay,
So I think the placement,
Yeah.
I think right now CUC has 15 openings for MAs. So if
Okay.
we graduated our class tomorrow, technically all of them have jobs.
okay,
And we have, some need as well. So I think if we can actually graduate 25 MAs within this fiscal year, I mean, that is feeding the system with individuals that we're training ourselves. And so, lots of really good opportunity there.
okay. And then the CHW and the nurse residency, is that a future activity, or are those in place?
CHW, we've got the curriculum. We're working with the state so that we can actually certify individuals.
Okay.
And so that's our rate limiting step. We've got individuals on board. Recruitment will be really quick.
Okay.
And so the goal is to get that program up and running this fiscal year. It's going to be August, September, so it's going to be close. The
Okay.
nurse residency, as we are prepping business cases, we're still working that one up.
Okay, okay. All right. Thank you very much. Oh, Dr. Lee, did you want to say something?
I love this program, and I love the concept, Manager Valdez, of growing our own. And I would just offer a thought that the landscape for the medical health professions and the doctors and specialists in Austin is substantially different today than it was before the medical school was here. So while no institution is perfect, and I'm not sure about the policies around recruiting locally and so on, and I'd love to learn, when I take a step back, and I am a little more familiar with where the graduates go, and I am familiar that a much higher proportion of Del Med School's graduates stay in Texas, and many stay locally here in the Greater Austin area. We are undoubtedly better off to have them here, and we are growing our own. I think our investment in the medical school has been transformational and critical for the space, and just wanted to state that. And I do think we're working in close partnership with them, and that should be a point of pride, I would say, our strategic involvement in that institution and that part of our vital health workforce.
Yes, I'd like to second that, because I mean, my comment was made quasi in jest, but that it's been study after study has shown that having a medical school in place, residents stay where they do their residency training. So, I think the med school benefit's been dramatic. But.
Yeah, I think we're just perhaps suggesting there may be some work to be done in collaboration with the medical school to help them focus some more in our community. Did you want to say something?
Is that reflection in diversity, though? In terms of graduate residents coming in that are diverse? That's what I was trying to get.
That's a very good question. I don't know that I know the data immediately. Alan, do you have information on this?
I don't know the stats, but they do have significantly diverse classes. And I know that the med school has that, so we could get that very easily.
I think it would be very helpful. I would appreciate it.
Absolutely.
If I may add something, the problem has been really in recruiting undergraduates, underserved populations into medical school. The system is not really geared towards that. And I think that's where the failing occurs. I think Del has a very diverse medical school population, but I think there's very few African Americans. I have several Hispanic students I'm teaching now, but I think that the pool available is beyond the scope of what the medical school is doing. It comes back to high school and college and the sort of the loading of the weapon to get it to go to medical school. So.
Well, I hear what you're saying. I would somewhat, if we're looking locally, yes, that may be true. But I do think nationally, and even within the state of Texas, we should be able to address that disparity. Is my opinion. I mean, so enough said.
Okay. All right. Thank you, Dr. Shelsa. All right, managers, our last item is to confirm the next Strategic Planning Committee meeting date, time, and location. It's tentatively scheduled on Wednesday, May 22nd at 4 p.m. at the Central Health Administrative Offices. That's here, 1111 East Cesar Chavez. At this time, I'm ready to accept a motion for adjournment from Manager Jones, seconded from Dr. Martin. All in favor? Aye. Okay. We are adjourned. Thank you, everybody.